Welcome, NCLEX warriors. In today's video titled Pediatric Pharmacology of the Musculoskeletal System, we will cover key medications used in children with fractures, bone disorders, and post-op recovery, focusing on safe use, side effects, and NCLEX-style scenarios. We post new high-yield videos daily, packed with the most important topics and questions you need to pass the NCLEX. So make sure to watch till the end, follow our channel, and stay tuned every day for essential exam prep that gets you closer to your RN dream. Quick pause before we jump into the questions. Are you NCLEX ready? If not, the complete NCLEX Review online course gives you everything you need: 100 hours of animations, 500 hours of recorded lectures, 5,000 top-rated questions, 500 NGN case-based study, and 15 CAT-style mock exams. It also comes with a detailed NCLEX ebook. All yours for an entire year. Limited time offer. Get 70% off today. Thousands have passed. Now it's your turn. Visit our website using the link below. Now let's start our journey with a high-stakes nursing moment. Here comes question number 1. A 7-year-old child who is recovering from an appendectomy is refusing to participate in post-operative ambulation despite clear instructions from the nursing team. Recognizing the child's developmental stage and the importance of early mobilization, which approach by the nurse is most developmentally appropriate to encourage compliance? Let us look at the possible nursing actions. Option A. Allow the child to choose between ambulating at 9 a.m. or after lunch at 1 p.m. Option B. Offer to bring a tablet for entertainment only after the child ambulates. Option C. Inform the child that not ambulating could result in further complications and discomfort. Option D. Report the behavior to the healthcare provider for behavioral evaluation. Before we go further, let us pause and think about how children at this age respond to choices and routines. The most effective and appropriate intervention is option A. Allow the child to choose between ambulating at 9 a.m. or after lunch at 1 p.m. Now, let us dive deeper into why this is the best choice from a developmental and clinical perspective. When caring for a 7-year-old, it is essential to recognize that they are in Erickson's stage of industry versus inferiority. This is the period where children begin to develop a sense of competence and control over their environment. By giving the child a choice between 2 scheduled ambulation times, the nurse empowers the child to take ownership of the task, which dramatically improves cooperation. This small but strategic offer of autonomy promotes internal motivation, decreases resistance, and shows respect for the child's growing independence, all while still achieving the nursing goal of early ambulation. Additionally, this method enhances the therapeutic alliance between the nurse and the child, reinforcing trust and participation in care. It is not just about getting the child moving. It is about engaging them in a way that aligns with their developmental needs and psychological comfort. Now, let us explore option B, which might seem like a practical solution on the surface. Offering a tablet as a reward may yield short-term success, but it introduces a pattern of external motivation that can undermine long-term cooperation. Children may begin to expect something in return for every action, weakening their intrinsic desire to participate in their own recovery. More importantly, using gadgets as behavioral currency can blur the line between healthcare goals and reward systems, especially in children who are easily influenced by instant gratification. In NCLEX testing and real-life clinical practice, nurses are expected to use positive reinforcement, praise, and age-appropriate communication rather than bribes. As for option C, while the warning is medically accurate, this fear-based tactic is not developmentally appropriate. Children in this age group may not grasp the connection between current actions and future complications. Instead of promoting understanding, it might instill fear or even guilt, which can backfire by increasing resistance and anxiety. Fear-based communication undermines trust, which is crucial in pediatric care. It is much more effective to use clear, gentle explanations paired with choices that give the child a sense of control over the situation. Turning to option D, it is important to recognize that occasional behavioral resistance in hospitalized children is not unusual and does not automatically warrant psychiatric referral. Reporting the child to the healthcare provider for behavioral evaluation is premature at this stage. Most children respond well to basic, developmentally grounded strategies such as offering choices, providing reassurance, and giving positive feedback. Behavioral referrals are generally reserved for patterns of persistent defiance or behaviors that interfere significantly with care despite multiple nursing interventions. In this scenario, the nurse is fully capable of addressing the issue using developmentally sound, non-threatening approaches. Let us seal this question with a key insight that every NCLEX student should hold on to. Children do not just need orders, they need options that respect their developmental growth. Empowering them with structured choices not only enhances compliance, but also builds trust, supports emotional development, and improves recovery outcomes. Remember, in pediatric nursing, how we say something can matter just as much as what we are trying to achieve. Let us move right into another must-know pediatric orthopedic concept with question number 2. A 7-year-old child is being transported to the emergency department with a suspected avulsion fracture of the left tibia sustained during a soccer game. As the nurse prepares to receive the client, which description most accurately defines the nature of an avulsion fracture? Let us explore the possible answers provided for this scenario. Option A, a fracture in which the bone bends but does not completely break. Option B, a fracture that spirals around the bone due to a twisting force. Option C, a fracture that pulls a part of the bone from the tendon or ligament. Option D, a fracture that results in bone shattering into multiple fragments. Based on knowledge of pediatric bone injuries and traction forces, the most accurate definition is option C, a fracture that pulls a part of the bone from the tendon or ligament. Now, let us uncover why this answer is not only correct, but also highly relevant for emergency pediatric care. Avulsion fractures occur when a powerful muscle contraction or sudden trauma causes a tendon or ligament to forcibly pull a small piece of bone away from its main structure. This is especially common in children due to the vulnerability of their growth plates, which are structurally weaker than surrounding connective tissues. These injuries typically occur during physical activities involving rapid acceleration or deceleration, just like soccer. What makes this type of fracture unique is that the primary force is not from impact or compression, but from internal muscle tension transmitted through tendons and ligaments. Understanding this mechanism allows nurses to anticipate which types of activities and presentations may indicate an avulsion injury and to prioritize stabilization and orthopedic referral promptly. Now, shifting focus to option A, let us clear up a common point of confusion. This answer describes a torus or buccal fracture, not an avulsion fracture. Buccal fractures occur when compressive forces cause the bone to bend inward, typically after a fall or axial load like jumping. They are common in children due to bone flexibility, but are stable and typically not caused by soft tissue tension. While both buccal and avulsion fractures are frequent in pediatrics, their causes and implications are completely different. And it is crucial for NCLEX candidates to be able to distinguish them based on mechanism and clinical context. As for option B, we need to focus on how different the force pattern is in spiral fractures. Spiral fractures result from a twisting motion that wraps the break around the shaft of the bone in a corkscrew pattern. These are often seen in rotational trauma or suspicious injury patterns like child abuse. Unlike avulsion fractures, spiral fractures are associated with torque and do not involve tendons or ligaments pulling on the bone. Identifying the right mechanism of injury helps guide imaging choices and alerts the nurse to potential safety or social concerns when appropriate. Now turning to option D, this describes a comminuted fracture, where the bone breaks into 3 or more pieces, usually due to a high-energy impact like a car accident. Comminuted fractures are uncommon in healthy children who sustain injuries during sports, especially without severe trauma. They involve crushing force, not the traction seen in avulsion injuries. Avulsion fractures, by contrast, are typically small and localized, often involving growth plates, and are caused by indirect tension from soft tissues rather than direct crushing trauma. Let us wrap this question with a critical clinical insight. When evaluating fractures in pediatric clients, always think about the force involved. Was it compression, traction, twisting, or impact? That single distinction can guide everything from initial assessment and splinting to which provider you notify and what type of imaging may be required. In children especially, growth plates and soft tissue connections make them prone to unique injury patterns like avulsions, and recognizing those patterns early leads to faster recovery and better outcomes. Let us continue building your pediatric NCLEX mastery. Here comes your question number 3. A 6-month-old infant presents with delayed motor milestones, bowed legs, excessive sweating, irritability, and delayed closure of the anterior fontanelle. Laboratory findings reveal low serum calcium and phosphorus levels. Based on these clinical and laboratory findings, which condition should the nurse most strongly suspect? Let us now look at the possible diagnoses the nurse may consider in this case. Option A, spinal muscular atrophy. Option B, rickets. Option C, infantile scoliosis. Option D, congenital hypothyroidism. Based on both the physical signs and laboratory findings, the most accurate diagnosis is option B, rickets. Now let us unpack why rickets fits this clinical picture so clearly. Rickets is a condition that results from a deficiency in vitamin D, calcium, or phosphorus, all of which are essential for healthy bone mineralization. In infants, classic signs of rickets include bowed legs, delayed closure of fontanelles, poor motor development, and increased sweating, particularly on the scalp. The bones remain soft and pliable due to poor mineral deposition, which leads to the visible skeletal deformities described. Laboratory results showing low calcium and low phosphorus levels further support this diagnosis, making it essential for nurses to not only identify these red flags, but also educate caregivers on the importance of vitamin D supplementation, especially for breastfed infants or those with limited sun exposure. Now, turning our attention to option A, let us examine why spinal muscular atrophy is not the right fit. While spinal muscular atrophy does involve motor delays and generalized hypotonia, it is a neuromuscular disorder that affects the motor neurons, not the bones. Infants with this condition may appear floppy and have difficulty controlling head and limb movements, but they do not present with bowed legs or mineral abnormalities. The underlying issue in spinal muscular atrophy is progressive muscle atrophy due to motor neuron loss, not bone softness from nutritional deficiency. The absence of biochemical evidence such as low calcium or phosphorus helps us confidently rule this one out. Next, let us take a closer look at option C, which mentions infantile scoliosis. This condition refers specifically to a curvature of the spine that develops in early childhood, often detected around the time a child begins to sit or walk. However, infantile scoliosis does not present with bowed long bones, fontanelle abnormalities, or the biochemical disturbances seen here. It is primarily a structural spinal deformity and not linked to systemic mineral deficiencies. Because this question includes broader physical findings and laboratory imbalances, scoliosis does not align with the clinical picture. Lastly, considering option D, it is important to understand that congenital hypothyroidism can indeed cause global developmental delays and poor growth. However, the signs presented in this case, particularly bowed legs, irritability, and biochemical findings like low calcium and phosphorus, are not hallmark features of hypothyroidism. Instead, hypothyroidism typically presents with symptoms such as prolonged jaundice, constipation, hypotonia, and laboratory values, showing elevated thyroid-stimulating hormone and low thyroxine levels. Since the skeletal symptoms here are quite specific and prominent, congenital hypothyroidism is not the most likely diagnosis. To drive this point home for your NCLEX prep, when you see bowed legs, delayed milestones, and low calcium and phosphorus in an infant, think rickets first. It is a condition rooted in bone metabolism, not neuromuscular dysfunction or spinal deformity. Early recognition by the nurse allows for timely intervention with vitamin D and nutritional support, preventing irreversible skeletal changes and promoting healthy growth and development. Nurses play a vital role in screening, educating, and supporting families at risk for this preventable but significant disorder. Let's tackle the next challenge with question number 4. A pediatric nurse is caring for a child diagnosed with osteogenesis imperfecta. Given the fragile skeletal condition associated with this disorder, which nursing intervention takes highest priority in minimizing complications for this client? Take a moment to consider which of the following actions is most essential. Option A, encouraging frequent repositioning to reduce skin breakdown. Option B, using gentle handling techniques and environmental safety measures to avoid fractures. Option C, providing heat therapy for muscle tension after daily activities. Option D, promoting passive range of motion exercises to preserve joint mobility. Among these options, the one that addresses the most immediate and high-risk concern is option B, using gentle handling techniques and environmental safety measures to avoid fractures. Let us now explore why this response stands out as the top nursing priority. Osteogenesis imperfecta is a rare genetic disorder characterized by extremely brittle bones, caused by a defect in collagen production. This means that even minor handling, repositioning, or unexpected environmental contact can lead to painful and sometimes life-altering fractures. That is why the nurse's first responsibility is not just to treat symptoms, but to prevent injury before it happens. Safety measures such as using foam padding, lifting the child with supportive techniques, and eliminating fall risks from the surrounding environment are crucial. Education also plays a vital role. Both healthcare providers and caregivers must be thoroughly trained on how to handle, diaper, transfer, and position the child without applying pressure that could result in fractures. Injury prevention is the foundation of care for this vulnerable population and can dramatically reduce hospitalization, deformity, and long-term disability. Now turning to option A, it is true that frequent repositioning is an important nursing goal for immobile patients to prevent pressure injuries. However, in the context of osteogenesis imperfecta, this must be approached with extreme caution. The irony here is that while repositioning may help the skin, if not done properly, it can actually cause harm by triggering fractures. Therefore, while relevant, it does not take precedence over the higher priority of skeletal protection. In fact, safe repositioning becomes a subset of gentle handling techniques rather than a standalone top priority. Next, let us examine option C, which focuses on heat therapy. While heat may soothe muscle tension and provide some comfort after limited physical activity, it plays no direct role in addressing the life-altering risk of fractures. Moreover, in a condition like osteogenesis imperfecta, over-relaxing tissues or improper heat application can actually compromise joint stability or lead to skin damage, which is another concern in fragile clients. Supportive therapies like this can be helpful but must be secondary to fracture prevention strategies. Now let us consider option D, which deals with promoting passive range of motion exercises. While maintaining joint flexibility and preventing contractures are legitimate goals in pediatric rehabilitation, these exercises must be tailored specifically for clients with osteogenesis imperfecta and always supervised by trained therapists. Even well-intentioned motion exercises can lead to accidental fractures if not adjusted to the child's fragility. So, although mobility support matters, it must be done cautiously and never prioritized over environmental and handling safety. To drive this point home, when caring for a child with osteogenesis imperfecta, injury prevention is not just part of the plan, it is the plan. Nursing care must revolve around eliminating fracture risks in every aspect of daily care. Whether lifting the child, changing linens, adjusting pillows, or even brushing hair, every action must be performed with bone protection in mind. That mindset keeps these children safe and supports their long-term development and quality of life. Now, let us keep the momentum going with a pediatric infectious disease scenario. Here comes your question number 5. An 8-year-old child presents with progressive swelling and pain in both knees. The parent reports that the symptoms began suddenly and have continued to worsen. The nurse suspects possible Lyme disease based on this presentation. Which additional assessment question would best support this preliminary diagnosis? Take a moment to reflect on which question would best guide the nurse toward confirming the suspicion. Option A, has the child been experiencing headaches, fatigue, or sore throat recently? Option B, have you noticed any unusual bruising or bleeding from the gums? Option C, has there been recent travel to an area with known waterborne parasites? Option D, has your child had any episodes of abdominal cramping after meals? The most useful and targeted assessment to support a potential diagnosis of Lyme disease is option A. Has the child been experiencing headaches, fatigue, or sore throat recently? Now, let us understand why this question strengthens the diagnostic picture. Lyme disease, which is caused by the bacterium Borrelia burgdorferi and transmitted by ticks, often begins with vague systemic symptoms before progressing to joint involvement. Early signs may include fatigue, malaise, low-grade fever, headache, and sore throat, symptoms that are frequently mistaken for viral infections. These nonspecific manifestations can either accompany or precede joint swelling, especially in weight-bearing joints like the knees. Even when the hallmark erythema migrans rash is absent, asking about flu-like symptoms helps nurses determine whether Lyme disease could be progressing to the early disseminated or late stage, where musculoskeletal symptoms become prominent. In pediatric clients, Lyme arthritis can be one of the first signs noticed by caregivers, so combining it with systemic symptom review is a smart and clinically sound assessment strategy. Let us now turn to option B, which introduces symptoms of bleeding such as gum bleeding and bruising. While these signs certainly warrant investigation, they are typically associated with hematologic conditions like thrombocytopenia or leukemia, not with Lyme disease. Borrelia infection does not cause clotting disorders or coagulopathy, and there is no direct link between Lyme disease and bleeding tendencies. Including this question in the assessment may lead the nurse down an unrelated diagnostic path, potentially delaying appropriate intervention. Now considering option C, this one focuses on recent travel to areas with known waterborne parasites. Although travel history is always important, this question shifts the focus toward parasitic infections like Giardia lamblia, which primarily affect the gastrointestinal tract. These infections typically present with symptoms like abdominal cramps, diarrhea, and bloating, not joint swelling or systemic flu-like signs. This question is not aligned with the suspected condition and would not add value to the current assessment for Lyme disease. Next, let us look at option D, which explores gastrointestinal symptoms like abdominal cramping after meals. While this question might be relevant for exploring food intolerances or irritable bowel syndrome, it does not relate to an infectious cause of arthritis. Lyme disease does not present with gastrointestinal involvement as a primary or secondary symptom, and pursuing this line of questioning would likely mislead the assessment away from the core musculoskeletal and infectious nature of the complaint. To summarize the key takeaway for NCLEX success, Lyme disease can be sneaky, and early signs often mimic a common cold or flu. That is why nurses must be trained to ask targeted, developmentally appropriate questions that capture the subtle onset of this condition, especially when joint symptoms appear later. Even in the absence of a rash or known tick bite, combining systemic symptom history with musculoskeletal findings leads to faster diagnosis, earlier treatment, and better outcomes for pediatric clients. Time to trust your nursing instincts. Here comes your question number 6. A pediatric nurse is providing discharge teaching to the parents of a child who has just received a plaster cast for a forearm fracture. Which parent statement indicates the need for immediate follow-up education? Let us review the possible responses that reflect varying levels of understanding. Option A, we should keep the casted arm clean and dry at all times. Option B, my child can use a blow dryer on the cool setting if the skin under the cast itches. Option C, I plan to apply lotion around the cast edges if my child says it is itchy. Option D, we will make sure he avoids inserting anything inside the cast. Among these statements, the one that signals a potential risk and a need for immediate clarification is option C. I plan to apply lotion around the cast edges if my child says it is itchy. Now let us explore exactly why this particular response raises a red flag. Applying lotion around the edges of a plaster cast may seem harmless or even soothing, but in reality, it can be problematic. Lotions can seep under the cast and create a moist environment that fosters skin maceration, irritation, and even fungal or bacterial infection. Since plaster casts are already at risk of retaining moisture, introducing any substance that traps or holds water against the skin adds to the complication risk. Moreover, once moisture is beneath the cast, it becomes nearly impossible to dry out without cast removal. This parent's intention is understandable. They are responding to their child's discomfort. But the approach can lead to more serious complications than the itching itself. This is a teachable moment where the nurse must redirect the parent to safer strategies for comfort and reinforce that dryness is one of the most important principles in cast care. Now, let us consider option A, which reflects a solid understanding of post-cast care essentials. Plaster casts are highly susceptible to damage from water exposure. If they get wet, they can lose their structural integrity, leading to poor immobilization and increased risk of infection. Teaching caregivers to keep the cast dry during baths and avoid water exposure in daily routines is one of the first and most emphasized instructions during discharge. This parent response is appropriate and does not require correction. Turning to option B, this might surprise some students, but yes, using a blow dryer on the cool setting is actually a recommended strategy for alleviating itching beneath a cast. Unlike inserting objects or applying products, cool air provides safe and non-invasive relief without compromising the integrity of the cast or causing skin damage. The key here is that it must be on the cool setting only. Heat can cause burns or make the cast material shrink or deform. As long as the parent understands this distinction, their plan is both effective and safe. Now looking at option D, this is an important precaution that many parents are warned about during cast care education. Inserting pencils, coat hangers, or any object into the cast to scratch an itch can cause skin tears, pressure sores, bleeding, or introduce bacteria that leads to infection. Children may be especially tempted to do this, but clear education and supervision can prevent such actions. This parent's statement reflects good awareness and aligns with safe cast care guidelines. Let us close this question with a valuable nursing insight. Cast care education is not just about keeping the cast intact. It is about protecting the skin and tissues underneath. Any action that introduces moisture or friction under the cast can result in complications that require recasting or even surgical intervention. Nurses must teach families practical, safe strategies for comfort while firmly avoiding products like lotions or powders. Empowering caregivers through thorough discharge teaching can dramatically reduce complications and promote a smooth recovery for pediatric clients. Before we get started, let me ask, what's your NCLEX plan? If you don't have one yet, we've got you covered. The complete NCLEX review course includes 100 animated hours, 500 hours of deep lecture content, 5,000 exam questions, 500 NGN case studies, and 15 full-length mock tests. Also included, a 1-year ebook guide. And yes, it's 70% off right now, but hurry. This offer won't last long. Click the link in the description and enroll today. Now, let us dive into a foundational pediatric condition that every NCLEX student must understand. Here comes your question number 7. The nurse is developing a care plan for a 5-year-old child newly diagnosed with cerebral palsy. To best support long-term mobility and minimize the risk of joint contractures, which nursing intervention should take priority? Let us go through the possible strategies a nurse might include in this care plan. Option A, establishing a consistent daily routine of stretching and passive range of motion exercises. Option B, allowing the child to rest as much as possible to reduce spastic episodes. Option C, encouraging the use of weighted resistance training to build muscle strength. Option D, administering oral baclofen as the first-line intervention for improving mobility. The priority intervention that directly targets the prevention of contractures and promotes long-term function is Option A, establishing a consistent daily routine of stretching and passive range of motion exercises. Let us now expand on why this is such a critical element in cerebral palsy care. Children with cerebral palsy often experience increased muscle tone and spasticity that can lead to contractures, permanent tightening of muscles, tendons, or ligaments that restrict movement. By integrating daily passive and active range of motion exercises, the nurse helps maintain joint flexibility, prevent muscle shortening, and support overall functional mobility. These exercises become especially important in children who have limited voluntary control of certain muscle groups. Starting early and being consistent can delay or even prevent the need for surgical interventions later in life. These stretching routines should always be adapted to the child's abilities and guided by physical therapy professionals as part of a comprehensive, individualized care plan. Now moving to Option B, while it may sound comforting to allow rest to reduce spastic episodes, it actually works against the primary goal of maintaining mobility. Inactivity contributes to increased stiffness, decreased circulation, and faster development of contractures. Children with cerebral palsy benefit from gentle movement and structured therapy, not prolonged rest. Encouraging too much inactivity can create a cycle of deterioration where spasticity worsens and joint function declines. Nurses must balance rest with proactive interventions to ensure musculoskeletal health. Next, let us look at Option C, which proposes weighted resistance training. Although strength training has its place in some pediatric rehabilitation plans, children with spastic cerebral palsy often lack the neuromuscular control required for safe use of weighted exercises. Resistance training can unintentionally increase muscle tone and stress joints that are already vulnerable. For these children, the focus should remain on improving flexibility, balance, posture, and fine motor coordination. Weighted workouts are not typically part of the early management plan and may actually pose a risk of injury if used incorrectly. As for Option D, baclofen is indeed a commonly prescribed muscle relaxant that helps reduce spasticity. However, medications like baclofen should be viewed as supportive, not curative. They provide symptom relief but do not address the mechanical issues involved in contracture formation. Medications alone cannot preserve range of motion or improve mobility if physical exercises are neglected. Nurses must educate families that drug therapy is an adjunct, not a substitute, for daily therapeutic exercises and consistent physical interventions. To wrap this up with a clinical gem, in cerebral palsy, preserving mobility is not just about reducing spasticity. It is about building a foundation of movement through daily therapy routines. Passive range of motion exercises are one of the most powerful tools a nurse can use to prevent complications, delay deformities, and empower families to support their child's long-term independence. It is a team effort, and nurses are on the front lines of that care strategy. Can you think fast and act smart? Let's find out. Question number 8. A nurse is evaluating a pediatric client in the emergency department who presents with a tibial fracture. The chart reveals that the child was recently discharged for previous fractures involving the radius and clavicle. Based on this history, what should the nurse be most concerned about? Let us carefully consider the possible explanations for this pattern. Option A, accidental trauma during unstructured play. Option B, juvenile idiopathic arthritis. Option C, osteogenesis imperfecta. Option D, physical abuse. The most concerning and urgent possibility in this case is Option D, physical abuse. Now let us unpack why this response carries such critical weight. When a child presents with multiple fractures involving different bones over a short period, especially in various stages of healing, it raises serious concerns for non-accidental trauma, also known as physical abuse. The nurse's role here goes far beyond documenting injuries. It involves using clinical observation, knowledge of injury patterns, and mandated reporting laws to protect the child. Unlike accidental injuries, abuse-related trauma often lacks a consistent or developmentally plausible explanation. It is not just the number of fractures that raises concern, it is the timing, location, and history behind them. The priority is clear. The nurse must initiate an immediate child abuse screening and notify both the physician and social services. Acting early can interrupt a dangerous cycle and provide safety for the child who may not be able to advocate for themselves. Turning now to Option A, while it is true that active children frequently get bumps and bruises during unstructured play, there is a difference between the occasional fall and multiple unexplained fractures across different limbs. Most developmental injuries follow a predictable pattern consistent with age and activity level, and they typically affect the same area if repetitive. This child's pattern of trauma, including recent fractures to the tibia, radius, and clavicle, strongly exceeds the threshold of what would be expected from roughhousing or outdoor play. Assuming this as an explanation risks missing a case of serious harm. Looking next at Option B, juvenile idiopathic arthritis does cause joint inflammation, morning stiffness, and discomfort, but it does not cause bone fractures. Children with this condition may limp or avoid activity due to joint pain, but their bones remain structurally intact unless compromised by another condition or trauma. The absence of joint swelling or other autoimmune symptoms further reduces the likelihood of this being the cause of the fractures. Jumping to this diagnosis would distract from the far more urgent possibility of abuse. Now let us review Option C, which introduces the idea of osteogenesis imperfecta, a real and serious condition, but one that is typically diagnosed earlier and comes with additional physical indicators. Children with osteogenesis imperfecta often present with features like blue sclera, brittle teeth, short stature, or hearing loss. If none of these findings are documented, and there is no existing diagnosis, the nurse should not jump to rare genetic explanations before ruling out abuse. It is important to investigate all possibilities, but safety and immediate risk must always take precedence in pediatric care. To bring this critical teaching point home, in any pediatric case involving multiple fractures across different body parts and timeframes, your first responsibility is to suspect and rule out physical abuse. While differential diagnoses are essential in nursing care, so is mandated reporting and protection. Nurses are legally and ethically obligated to act when a child's safety may be at risk. Recognizing injury patterns, asking the right questions, and involving social services early can quite literally be the difference between life and ongoing harm. Let us now shift our focus to a common orthopedic issue in infants: developmental dysplasia of the hip. Here comes your question number 9. The nurse is preparing to initiate care for an infant recently diagnosed with developmental dysplasia of the hip. Based on standard treatment protocols, which intervention should the nurse expect the primary healthcare provider to prescribe? Let us take a look at the potential interventions being considered for this condition. Option A, hip spica cast application within 24 hours. Option B, use of a compression garment to promote joint alignment. Option C, swaddling the infant tightly with the hips extended. Option D, application of a Pavlik harness to maintain hip positioning. The correct and most commonly prescribed intervention for early treatment is Option D, application of a Pavlik harness to maintain hip positioning. Now let us dive into why this intervention is considered the gold standard for infants under 6 months with developmental dysplasia of the hip. The Pavlik harness is a soft, adjustable device that holds the infant's hips in flexion and abduction, precisely the position needed to help the femoral head align properly within the hip socket or acetabulum. This positioning allows the hip joint to develop normally and often prevents the need for invasive treatments later. The earlier the harness is applied, the greater the chance for a successful non-surgical correction. As a nurse, it is essential to educate caregivers on how to care for the harness at home. This includes avoiding unnecessary removal, monitoring skin under the straps for irritation, and understanding that diapering must be done without disturbing the position of the harness. This simple yet powerful intervention helps reshape a child's musculoskeletal development, giving them the best possible start in life. Now turning to option A, it is important to recognize that a hip spica cast is not the first-line treatment for developmental dysplasia of the hip in newborns or young infants. Spica casts are typically reserved for children who are older, or for cases where the Pavlik harness fails and surgical intervention, such as a closed reduction, is required. Initiating a hip spica cast within the first 24 hours of diagnosis would be premature and inappropriate for conservative management. Furthermore, casting significantly limits infant mobility and presents more care challenges, including hygiene concerns and skin breakdown. Let us now consider option B, which suggests using a compression garment to manage hip alignment. This choice is not appropriate because compression garments are designed to manage fluid buildup or support vascular return in conditions such as lymphedema, not orthopedic abnormalities. They do not offer the joint-specific positioning or support needed to correct developmental dysplasia of the hip and would offer no benefit in this case. Including this intervention in the plan of care would reflect a lack of understanding about the condition's orthopedic nature. Next, looking at option C, this choice actually reflects a practice that increases the risk of developmental dysplasia of the hip rather than treating it. Swaddling infants too tightly with the hips extended and adducted limits proper hip development by forcing the femoral head out of optimal alignment. In fact, tight swaddling is a known contributor to the development of developmental dysplasia of the hip in infants. Nurses must educate families to swaddle infants in a way that allows the legs to bend and move freely, often called the hip-healthy swaddle. Promoting safe sleep and swaddling practices is a critical role for pediatric nurses in both prevention and treatment. To leave you with an essential NCLEX-ready insight, the Pavlik harness is the cornerstone of early developmental dysplasia of the hip management and is both effective and non-invasive when used correctly. It allows for natural hip development with minimal disruption to daily routines when caregivers are properly educated. Nurses play a vital role not only in identifying developmental dysplasia of the hip early, but also in reinforcing the safe use of this device and preventing harmful practices such as improper swaddling. Early intervention here makes all the difference in a child's ability to walk, move, and thrive. Get into nurse mode. Here comes question number 10. A 3-month-old infant is evaluated for unexplained fractures involving the ribs and long bones. The nurse also observes blue sclera, and the parents mention a family history of fragile bones and recurrent fractures. Based on these clinical findings, which diagnosis is most likely? Let us take a close look at the potential causes being considered. Option A, infantile rickets. Option B, osteogenesis imperfecta. Option C, spinal muscular atrophy. Option D, Ehlers-Danlos syndrome. The most likely and clinically supported diagnosis in this case is option B, osteogenesis imperfecta. Now let us explore why this diagnosis fits so clearly with the child's presentation. Osteogenesis imperfecta is a genetic disorder of connective tissue caused by mutations in the genes responsible for producing type 1 collagen. This collagen is essential for strong, structurally sound bones. When defective, the result is extreme bone fragility, which manifests in recurrent fractures from minimal or no trauma, exactly like we see in this infant. Other hallmark features include blue sclera, a result of the thin collagen layer in the eye that allows underlying veins to show through, and a family history of similar issues, which further supports the diagnosis. These features make osteogenesis imperfecta one of the most recognizable pediatric genetic disorders. The nurse must act promptly to initiate protective measures, educate the family about safe handling, and collaborate with the healthcare team to prevent further injuries and improve quality of life. Turning now to option A, infantile rickets may initially seem plausible because it also affects bone health. However, rickets is a metabolic bone disease caused by vitamin D deficiency, resulting in weakened bones and deformities, not spontaneous fractures. It does not typically present with blue sclera or a strong genetic component. Instead, rickets is associated with bowing of the legs and widened wrists, and would typically reveal hypocalcemia or hypophosphatemia on laboratory testing. The absence of these metabolic findings, along with the presence of blue sclera, points us away from rickets in this scenario. Now let us look at option C, spinal muscular atrophy. This is a neuromuscular condition caused by degeneration of motor neurons, leading to progressive muscle weakness and hypotonia. Although spinal muscular atrophy does lead to mobility issues, it does not directly cause bone fragility or fractures. The hallmark of spinal muscular atrophy is a loss of motor function, rather than abnormal bone structure or recurrent skeletal injuries. Therefore, this condition does not match the clinical picture described in the question. Lastly, option D introduces Ehlers-Danlos syndrome, another connective tissue disorder. While this syndrome does involve collagen abnormalities, its clinical manifestations differ significantly from those of osteogenesis imperfecta. Ehlers-Danlos syndrome is typically characterized by joint hypermobility, stretchy skin, and delayed wound healing. Fractures and blue sclera are not common features, and early infantile fractures are not a typical presenting sign. Misdiagnosing osteogenesis imperfecta as Ehlers-Danlos syndrome could delay critical interventions to prevent injury. So here is the key takeaway. When an infant presents with unexplained fractures, blue sclera, and a family history of fragile bones, osteogenesis imperfecta should be at the top of your differential. Early diagnosis empowers the nurse and the care team to implement safe handling techniques, educate the caregivers, and reduce the risk of future injury. It also opens the door for genetic counseling and long-term care planning. In NCLEX and real life, recognizing the classic signs of osteogenesis imperfecta can make all the difference in protecting a vulnerable child. Let us now focus on how to safely manage itching under a cast. Here comes your question number 11. The nurse receives a call from the parent of a 14-year-old adolescent who is experiencing persistent itching beneath a fiberglass leg cast for a tibial fracture. What is the most appropriate recommendation the nurse should provide to safely relieve the itching without compromising to cast integrity? Let us take a look at the available options that parents may consider. Option A, use a blow dryer set to the cool setting to direct air under the cast. Option B, sprinkle talcum powder into the cast to absorb moisture and soothe the skin. Option C, pour cool water inside the cast to relieve discomfort. Option D, use a cotton swab to gently scratch under the cast edges. The most appropriate and safest choice to recommend is Option A, use a blow dryer set to the cool setting to direct air under the cast. Now let us walk through why this recommendation is the gold standard for cast-related itching. Using a blow dryer on the cool setting to circulate air beneath the cast is a non-invasive, moisture-free way to soothe discomfort without damaging the cast material or injuring the skin. It allows for temporary relief without introducing moisture, objects, or foreign substances, which are the top causes of complications in cast care. Cool airflow helps dry sweat and reduces the irritation caused by trapped heat and dead skin cells inside the cast. Nurses must teach this technique during discharge education to equip caregivers with safe alternatives that do not compromise skin integrity or cast structure. Now shifting attention to Option B, this might sound like a comforting solution at first, but sprinkling talcum powder into the cast is actually discouraged. Talcum powder can clump together in warm, moist environments, especially under a cast, and become a breeding ground for bacteria and fungi. The powder may also irritate the skin, interfere with the cast padding, and lead to further discomfort or infection. Though it may seem harmless, it introduces unnecessary risk and offers little benefit. Next, let us explore Option C, which suggests pouring cool water into the cast. This is absolutely contraindicated. Introducing any water under a fiberglass or plaster cast can compromise its structure and lead to serious skin complications. Moisture trapped beneath the cast can soften the skin, cause maceration, promote bacterial or fungal infections, and result in pressure sores. Once wet, the cast may also lose its supportive function and require replacement. Nurses must educate caregivers that casts must remain completely dry at all times, even when attempting to relieve discomfort. Now looking at Option D, this represents a very common but highly unsafe mistake. Inserting cotton swabs, pencils, rulers, or any object under a cast to scratch an itch can lead to skin abrasions, infections, and disruption of the internal padding. These actions may seem minor, but can result in hidden injuries that are not visible until the cast is removed. Even soft materials like cotton can unravel or introduce fibers that irritate the skin and harbor bacteria. Nurses must reinforce that nothing should ever be placed inside the cast, no matter how itchy it becomes. To wrap this up with a key teaching point, cast care is about more than immobilization. It is about protecting the skin and preventing infection throughout the healing process. Cool air from a blow dryer is the safest method for itch relief that respects both cast integrity and skin safety. Every nurse should make this part of their standard discharge education for any client going home with a cast, especially in pediatric populations where itching is almost guaranteed. Safe guidance today prevents complications tomorrow. Let's simulate a real NCLEX moment. Here comes your question number 12. An adolescent is scheduled to undergo corrective spinal surgery and is expected to remain hospitalized for an extended post-operative recovery period. Understanding the unique psychosocial vulnerabilities of this age group, which nursing intervention best addresses the client's developmental needs during hospitalization. Let us walk through the possible nursing interventions being considered. Option A, recommend parental overnight stays to maintain family presence and reduce anxiety. Option B, facilitate in-person or virtual peer interaction to maintain social connection. Option C, promote journaling or solitary hobbies to encourage emotional expression. Option D, provide nutritional teaching to reinforce self-care and recovery behaviors. The intervention that most directly addresses the developmental needs of this adolescent client is Option B, facilitate in-person or virtual peer interaction to maintain social connection. Now let us unpack why this option is developmentally aligned with what adolescents need most. Peer relationships are central to an adolescent's self-identity, emotional regulation, and sense of social belonging. During hospitalization, especially one that involves limited mobility and an extended stay, this developmental need can be threatened, increasing the risk of social isolation, anxiety, and non-compliance. Facilitating peer connection, whether through hospital visits or video calls, offers a vital lifeline to normalcy. It helps maintain their social identity, reduces emotional distress, and even promotes better cooperation with care and rehabilitation. Nurses must recognize that adolescent care extends beyond pain control and nutrition. It includes supporting peer relationships as a clinical priority. Now looking at Option A, recommending overnight parental stays may be very helpful for young children. But for adolescents, this strategy may feel intrusive or overprotective. While family support still matters, adolescents are at a stage where autonomy and peer belonging take center stage. Excessive parental presence can unintentionally hinder the adolescent's need for independence. While families should be engaged in care planning, the emotional anchor for adolescents often comes from their peer group, not their parents. Turning to Option C, encouraging journaling or solitary hobbies can certainly help adolescents process emotions, but these are internal coping strategies. They do not meet the critical external need for social feedback, validation, and inclusion that peers provide. Journaling is a useful adjunct, but not a substitute for active peer interaction. Relying solely on solitary strategies can risk emotional isolation, especially in a hospital setting where adolescents already feel removed from their regular lives. Now considering Option D, nutritional education is always an important part of post-operative care, especially for healing and long-term health. However, teaching about food choices or self-care behaviors does not directly address the psychosocial vulnerability of adolescents. Adolescents may listen and comply, but their emotional engagement and satisfaction with care is largely shaped by how connected they feel to their peers and how well their need for social belonging is met. Here is your essential NCLEX takeaway. Supporting adolescent development during hospitalization means prioritizing their social world, not just their physical care. Nurses must create care plans that integrate emotional and social support strategies, particularly peer contact, to help adolescents maintain their identity, boost morale, and improve engagement in recovery. By recognizing the developmental significance of peer interaction, nurses help shape a more holistic and effective healing environment for teens navigating serious medical conditions. Hold on just a sec. Let's talk strategy. The Complete NCLEX Review online course is your fast-track prep kit. 100 animated hours, 500 hours of lectures, 5,000 questions, 500 NGN-style case studies, and 15 exam simulations. All this plus a year-long NCLEX ebook. Act fast, it's now 70% off for a limited time. Visit our site using the link in the description and start today. Let us now focus on safe and effective medication administration in pediatric trauma care. Here comes your question number 13. A nurse is preparing to administer intravenous ketorolac to a 10-year-old child with a femur fracture. The child is in moderate pain and surgery is not yet scheduled. Which consideration must the nurse prioritize before administering this medication? Let us take a look at the possible considerations the nurse might review. Option A, confirm that the child has fasted for at least 8 hours. Option B, assess the child's renal function and hydration status. Option C, administer with a high-fat meal to reduce gastrointestinal upset. Option D, pre-medicate with diphenhydramine to reduce itching risk. The most important and immediate consideration for safe administration is option B, assess the child's renal function and hydration status. Let us now explore why this precaution is critical when using ketorolac in pediatric care. Ketorolac is a non-steroidal anti-inflammatory drug that provides strong analgesic effects without the sedation associated with opioids. However, it comes with a significant risk of nephrotoxicity, particularly in children who may already be volume depleted due to trauma, bleeding, or dehydration. Ketorolac inhibits prostaglandin synthesis, which in turn reduces renal blood flow, something the kidneys rely on for proper filtration, especially under stress. Before administering this medication, the nurse must assess renal function through serum creatinine levels and ensure that the child is adequately hydrated to prevent acute kidney injury. This step is essential in balancing effective pain control with protection of organ function, especially when surgery may still be pending and fluid balance is already compromised due to the injury. Now, let us turn to option A, which brings up fasting. While fasting is a common pre-procedural or pre-surgical requirement, it is not relevant when administering ketorolac. This medication does not require an empty stomach and can be given with or without food, particularly since it is often administered intravenously in acute care settings. Requiring fasting before ketorolac administration could unnecessarily delay pain relief for a child who needs timely intervention. Always tailor pre-administration requirements to the specific pharmacologic properties of the drug being used. Next, looking at option C, this option focuses on giving ketorolac with a high-fat meal to prevent gastrointestinal irritation. However, this precaution is applicable to certain oral medications and does not apply to intravenous administration. High-fat meals can actually delay gastric emptying and are not relevant when the drug bypasses the digestive tract entirely. For ketorolac administered intravenously, gastrointestinal protection is achieved through dosing duration and avoiding use in patients with known ulcers or gastric risk, not through dietary adjustments. Now moving to option D, which suggests pre-medicating with diphenhydramine. This may sound familiar to those managing opioid-induced itching, but ketorolac is not associated with histamine release or pruritus. It is not an opioid and therefore does not carry the same risk of itching or allergic-type reactions in most patients. Administering diphenhydramine without cause introduces unnecessary sedation and the potential for other side effects, such as dry mouth or dizziness. Nurses should always align their pre-medications with the known side effect profile of the primary drug being given. Here is your clinical pearl to lock in. When giving ketorolac to a pediatric trauma patient, think kidneys first. Always check hydration status and renal labs before giving any medication that affects perfusion, especially in children with fractures and possible blood loss. Safe pain management is not just about controlling symptoms. It is also about protecting the organs that keep our clients stable and strong during recovery. If you were on the floor right now, how would you respond? Let's answer that in question number 14. A nurse is reviewing medications for a child with a long bone fracture who is receiving opioids for severe pain. Which concurrent prescription would most directly reduce the risk of a common adverse effect of opioid therapy in this population? Let us look closely at the potential options for managing side effects. Option A, ondansetron to prevent opioid-induced vomiting. Option B, furosemide to reduce fluid retention from inactivity. Option C, magnesium hydroxide to enhance bone healing. Option D, lorazepam to prevent opioid-induced hallucinations. The prescription that most directly targets a frequent and predictable side effect of opioid therapy is option A, ondansetron to prevent opioid-induced vomiting. Now let us examine why ondansetron is the ideal co-prescription in this setting. Opioids are well known to stimulate the chemoreceptor trigger zone in the brain, which often results in nausea and vomiting, particularly in pediatric clients, who are more sensitive to this effect. Ondansetron is a selective serotonin receptor antagonist that blocks this stimulation, making it an effective and well-tolerated choice for preventing opioid-induced nausea. By managing this side effect proactively, the nurse supports not only the child's comfort but also their ability to maintain oral intake and avoid dehydration. It also minimizes the risk of aspiration in cases where the child is post-operative or experiencing limited mobility. Teaching families about expected side effects and offering medications like ondansetron can significantly improve the child's pain management experience and reduce complications. Now turning to option B, the use of furosemide is not clinically appropriate in this situation. Furosemide is a loop diuretic used for fluid overload, not as a supportive medication for opioid therapy or fracture care. In fact, using furosemide unnecessarily could lead to hypovolemia, electrolyte imbalances, or impaired renal perfusion, especially risky when opioids are already slowing gastrointestinal and urinary systems. This option does not reflect evidence-based management of opioid side effects and may introduce avoidable risks. Looking next at option C, magnesium hydroxide is sometimes used to treat constipation, a common side effect of opioid use. However, it does not enhance bone healing. And in this context, the primary concern is not long-term constipation management but immediate, acute side effects. Magnesium hydroxide may be considered if constipation becomes significant, but it is not the first or most direct intervention required in the early phase of pain control. Additionally, improper use may cause diarrhea, which can interfere with recovery. Lastly, option D suggests lorazepam to prevent hallucinations. This is not standard practice. While opioids can rarely cause hallucinations, especially with high doses or prolonged use, they are not a typical concern in the standard pediatric dosing used for acute pain. Lorazepam is a sedative and anxiolytic that could impair neurologic assessment, reduce respiratory drive, or increase fall risk, especially when combined with opioids. Sedating a child unnecessarily adds risk without addressing the most predictable opioid-related symptoms. So here is your NCLEX-ready clinical pearl. When administering opioids to pediatric clients, proactively managing nausea with ondansetron can prevent one of the most common and disruptive side effects. It improves comfort, supports hydration and nutrition, and reduces complications like aspiration or vomiting-induced pain. Nurses play a vital role in anticipating these responses and advocating for supportive medications that make pain management more tolerable and effective. Let us wrap up this series with a high-priority, life-saving pediatric scenario that every NCLEX student must be prepared to handle and practice. Here comes your question number 15. A 7-year-old child is recovering from surgical repair of a complex humeral fracture. The child is receiving scheduled acetaminophen and has needed morphine. The nurse notices the child is quieter than usual and difficult to arouse. What is the nurse's immediate priority? Let us now go through the potential nursing actions under consideration. Option A, reassess pain score and offer fluids orally. Option B, notify the healthcare provider and prepare to administer naloxone. Option C, apply a warm compress to the surgical site to stimulate circulation. Option D, document the findings and reevaluate in 30 minutes. The most urgent and appropriate action in this case is Option B, notify the healthcare provider and prepare to administer naloxone. Now, let us take a closer look at why this is the correct and potentially life-saving intervention. When a child receiving opioids suddenly becomes difficult to arouse, the nurse must suspect opioid-induced central nervous system depression, which can rapidly lead to respiratory arrest. Morphine, while effective for pain relief, carries the serious risk of suppressing respiratory function, especially in pediatric clients, who are more sensitive to these effects. The presence of lethargy or decreased responsiveness is a red flag that must not be ignored. Naloxone is an opioid antagonist that reverses the effects of opioids quickly by displacing them from their receptor sites, restoring respiratory effort and alertness. In emergency pediatric care, the nurse must act fast, notify the provider, have naloxone readily available, and initiate emergency airway support if needed. This response reflects both critical thinking and rapid prioritization under pressure, which are cornerstones of safe pediatric practice. Turning now to option A, while reassessing pain and encouraging oral fluids are important under routine circumstances, they are completely inappropriate when the child is showing signs of sedation and possible respiratory depression. Offering fluids to a child with a compromised level of consciousness poses a serious aspiration risk. Pain scores become irrelevant if the client is too sedated to respond. This option overlooks the potentially emergent nature of opioid toxicity. Looking at option C, applying a warm compress may offer comfort at the surgical site, but it has absolutely no effect on central nervous system depression or opioid overdose. When a nurse suspects a systemic drug reaction, local interventions such as compresses are ineffective and distract from the real emergency. Time spent applying a compress is time lost that could be used for airway protection and life-saving medication. Now, considering option D, documentation is always an essential part of nursing care. But in this context, documentation without action could be fatal. Reevaluating in 30 minutes implies passive observation, which is unsafe when early warning signs of opioid overdose are present. Children can deteriorate rapidly, and hesitation in the face of altered mental status is one of the most dangerous responses. Immediate intervention must take priority over observation and charting when airway, breathing, and consciousness are at risk. To lock in this critical NCLEX teaching point, any sign of decreased arousability in a child receiving opioids must trigger an immediate response, not passive monitoring. The nurse's top responsibility is to protect the child's airway, assess for respiratory depression, and act swiftly with emergency medications like naloxone. Pediatric safety demands that nurses be proactive and responsive at the first sign of opioid toxicity, not wait until vital signs become critical. Quick action saves lives. And knowing this could be the question that helps you pass your NCLEX. That's it for today's session on pediatric pharmacology of the musculoskeletal system. We will be back tomorrow with another high-yield NCLEX topic, so stay tuned. We post daily videos packed with the most important concepts and questions you need to pass the NCLEX. Follow us, watch regularly, and make this part of your daily study routine, because your success starts with what you do today.